thank the chairperson and co-chairperson for introducing me, and the organization and Apollo for giving me this opportunity. So right after Professor Tyagi's talk, where he was about avoiding surgery, yes, I fully agree. The reason is mainly the scare of opening the chest and the trauma of recovering over months. But we have procedures in cardiac surgery which completely avoids chest opening, and patients recover very quickly, go home in 3 to 4 days, recover within 2 weeks with tiny holes in the chest, avoiding full sternal split. So robotic assist cardiac surgery and minimal invasive surgery. So robotic assist cardiac surgery is not new. It's been established over the last decade. And common surgery performed worldwide is mitral valve procedures. Now increasingly coronary artery bypass grafts procedures. As mentioned by our chairperson, we are one of the biggest centers in the world, the Apollo Group, and where we perform total arterial multi-vessel coronary artery bypass graft surgery. So that's patient positioning, peripheral cannulation for mitral valve procedures. And that's just a short video of how it is done. That's a valve repair procedure. So I'll just go through. So that's how good you can see. Everybody can see very well. So the whole repair can be done when everybody is able to see what is happening in theater. It can be taught to trainees very well. And that's how the end result is without any leak. Finally, it's closed. So that's mitral valve surgery with robot. So where we have 3 ports, and that's a video. I just want to show how clear it is to see and repair. It's almost like sitting inside the heart and doing things. So it's much easier because they have 360-degree movement, and the vision is 10 times magnified. It is not 2D, it is 3D. So it's much easier than open procedures to perform these repairs using robot. So this was the initial 1,000 patients by Mark Gilleneuve, which he published in 2018. He showed operating time was slightly more, but the mortality stroke risk was a lot less, and the recovery was extremely quick. Patients go home in 3 days, recover within 2 weeks. Mitral repair, atrial septal defects, atrial tumors, tricuspid repairs or replacements are now done in our center routinely by this approach. We tend to repair and not replace mainly the mitral valve because of its integrity to the ventricle and to avoid anticoagulation. As you all know, in our country, availability of INR is very variable, especially in peripheries. So these are the type of repairs which I won't go into. And the bypass procedures, now we do Da Vinci with robotic assist. It's been surging up in Europe over the last 4 years pre-COVID. About 27 centers in Europe have been performing routinely. And of that, you can see single mammary is the maximum. Less than 2% were bilateral mammary. Whereas in our practice, it's almost 70%. And you can see in the last graph, over the 4 years of study, it's doubled. The number of centers were doubled. And also comparing mortality, it is a lot less. The red line is the robotic assist procedures, lot less than observed mortality. So this was a recent review article published in Journal of American College of Cardiology, which showed not one, initially the mitral minimal invasive procedures were accepted as just reduced hospital stay and quick recovery, but with the use of robotic assist, it reduces complications rate early and late, and also mortality. And by using bilateral mammary, the long-term outcome is better as well than in open procedures. So it is becoming superior to open procedures. So the surgeon sits comfortably in one end of the theater, and this is done by 2 or 3 ports. So that's at the end of the procedure where we do direct anastomosis, and that's what the patient goes home with, 5 centimeters cut. So usually they are extubated within few hours. Day 1, they are mobilized. Day 2, they go to the ward, and day 3 or day 4, they go home. By the time we see them in clinic in 2 weeks, they are back to normal activity, which in your practice in occupational health, as occupational health providers, it will be not only good for the patients, but for the employers as well, for them to get back to work early, where it will provide an economic benefit for the family as well as employers. Advantages are 360-degree movement of the arms, high precision, high magnified vision, and as I've already mentioned, total arterial revascularization. These patients do not have cut in the legs. It is teamwork, and there are certain contraindications. Previous lung surgery is a contraindication, poor lung capacity, unstable patients, of course. So in our practice, about 80% of our patients we are able to offer through this technique. So this was a European review which looked at comparing CABG to robotic assist. They clearly showed incidence of major adverse cerebral and cardiovascular procedures was half of open procedures. So they concluded reduced infection rates, reduced MACE procedures. So that's already I've discussed. It is much better than minimal invasive and open procedures. That's a typical X-ray in day 1 post robotic assist. There's hardly any collapse of the lungs, which you don't see in open procedures of CABG or. So we also tend to treat more patients who might not have been suitable for open robotic procedures alone by combining stents to the right side and performing these to the left, especially elderly with more comorbidities, more than 80-year-olds and high Euro scores. Combining best of both worlds, we do a stage procedure, 2-stage procedure. These patients go home in 4 to 5 days. Again, the complication rate is a lot less in these group of patients who have high comorbidity in the octogenarians. There's no sternal split, no hybrid theater, and patients recover quickly. This was a study which looked at this group. It showed clearly hybrid was beneficial in the higher comorbid groups with high Euro score. So this was a publication in Journal of American College of Cardiology, which again showed incidence of complications, major adverse cerebral and coronary complications were less in the early as well as postoperative long-term in hybrid group, which was higher in the early phase in CABG group and later in the multivessel PCI group. This is our robotic experience over the last 3 years, or just over 3 years in Apollo, Chennai, and now in Delhi. We have mortality less than 2%, reoperation rate less than 4%, and the oldest patient we operated was 93. He is the oldest patient who underwent cardiac surgery in the country. So age group, about 25% are more than 70 years of age. High BMI is not a problem here. And we also treat patients with chronic kidney disease, lung disease, and Euro score more than 25%. Severe diabetic, we have had no infection so far because it's only the skin cut and there's nothing else cut underneath. And as I said, number of distals, multivessels are 70% of our practice. So more IMAs, 35% of our patients have had hybrid procedures. So number of ICU stays usually 1 to 2 days. Blood transfusion, most of them don't need. As you can see, almost 54% required only 1 unit, which can be avoided, which we are educating our intensivists as well. So who is it for, robotic CABGs? It's for most patients who are stable and mainly for diabetics who require total coronary artery revascularization. It is more comfortable. I'll show you a short video before I move on. It's just a 3 minutes video. So we put 3 ports on the left side first to start. Then the camera is inserted, and through camera guidance, other ports are inserted. The robo is then docked. That's the forceps and then the spatula. So we take down the mammary. As you can see, magnification is beautiful and the vision is extremely good. There's hardly any blood loss. If the patient bleeds, then it will be difficult to visualize. We tend to avoid blood loss, and it's usually very clean, and the branches are magnified and shown as well. So we have to clip and buzz them as we go. And we can take much longer. This is where me sitting in one side of the theater and operating, which is reflected to this currently through cables. In future, it can be remote with 5G and more. That is where we are heading towards. So then the clips are placed as required. Then the mammary is taken down nicely. I'll skip some. So that's how it is. It's clean, and we can take right up to the origin. So we get more length on the arteries. That's the reason we can avoid radial or veins from the legs. Patient goes home with just 2 holes on either sides of the chest. And then we open the pericardium posteriorly to let any blood out that bleeds in the postoperative period to avoid tamponade. Then we move on to the other side, same 3 ports, and then docking. Again, same thing, we take down the right, and we can go right up to the origin on the right side, the artery above which, sorry, it's not seen, yeah. So after clipping this, we cut anteriorly, which will not be possible even in open procedures. This part of the artery cannot be accessed by any other means except having the robo. So that gives us extra 3-4 centimeters, which is used to do all 3 or 4 grafts just by using the arteries alone. So I'll skip this, go to the end. So then we divide the mammary, take it out. With a spatula. Then we make a tiny hole, 5 centimeters, through which the anastomosis is done. Thank you.
Yeah, thank you so much, sir, for the brief session on the robotic surgeries. So, house is open for questions. So, if anyone has question, please, they may ask. Yes, sir. Okay. Sure, sure, sir. Sure, sir. Thank you so much, sir. I am very sorry. He has a flight to catch.
Yes, please.
Yeah.
India are developing these skills to learn robotic skills.
Sorry?
How the surgeons across India
Yeah.
developing, how they are learning robotics?
Yeah, currently it is not, currently I am the proctor for Southeast Asia. So I've been training surgeons across the country and in Asia as well. So we started first in Chennai, then Bangalore, Apollo, now in Delhi. Apart from Apollo, we have started in SGPGI Chandigarh and 2 other hospitals in Bangalore. Now we are starting in Max as well. And we are training surgeons across the country now. Probably in the next 5 years, we'll see more of it across the globe. Thank you.
Thank you. Can I ask one last question? Does ejection fraction plays a role in avoiding this surgery?
Yeah. So the group, the 20% which I said we avoid, are the patients who have poor ejection fraction with diffuse disease. If yes, similar. But in that group, if the other vessels are stentable, say like this 93-year-old, he had a severe left main where I did Lima LAD alone, and the other was stented. If they are suitable for stents, we can offer this hybrid approach. But in the elderly comorbid with poor LV, Lima LAD alone is not a problem because we don't manipulate the heart. Anything more will be difficult, which we are not doing now. But we are devising some more instruments to stabilize the heart with the robo. If once that comes to, probably in the next 1 to 2 years, we'll be able to address those patients as well.